Rick Chetney. I'm a radiation oncologist in veterinary medicine. And basically, my training kind of came up for the fact that I finished vet school, knew I wanted to specialize in something. So I did the next thing I thought was appropriate, and I took a rotating internship. And it was during my rotating internship that I worked with an oncologist and actually took a second rotation in oncology. And found that the clientele were just really appreciative. One, for the fact that we had a diagnosis of cancer, which is usually a fairly life-limiting type of diagnosis for many clients, but for the fact that we could give them more time, but only with quality. So really, quality of life is at the forefront of the treatment recommendations we make, and hopefully it's also in the forefront of the decisions that the family's making. So after my rotating internship, I went down to Knoxville, Tennessee, to the University of Tennessee in Knoxville, and completed a 12-month medical oncology internship. Applied again for a residency, did not break through in a residency, did a year of emergency, spun my wheels a little bit, threw in my hat for a residency a third time, and got denied for that as well. So one of my mentors back at the University of Tennessee at Knoxville, Nathan Lee, had an open position for a radiation oncology resident that he didn't fill. So myself needing a residency and him needing a resident, we decided this was a good thing, and the rest is kind of history. About 4 months in to this residency, I kind of found out exactly what radiation therapy was, and decided that that was actually a better career choice for me. So after graduating from residency 2015, I worked at VRC in Malvern, which is right next door to the Veterinary Cyberknife Center. Then took a job at VSEC, which is now Blue Pearl Levittown, with the linear accelerator they had there for about 3 years. That machine has now gone to Hope in Malvern, because they're also Blue Pearl now. And now I'm working at North Star Vets in partnership with our company, Pet Cure Oncology. And what I would say is that even though there's somebody else that signs the paychecks for myself and my team, we've really been welcomed into North Star as basically no different than any other service. We work and operate out of North Star Vets just like we are a part of the service of that hospital. We really feel no different in our support and how we work within the hospital. So thank you for North Star Vets for having me for this lecture tonight. I'm very happy to give you this information of a very small speck of what I've learned since my residency time. And it's actually a pretty high quality setup here, I would have to say. So Blake, thank you for that with the camera and the lights here. Oh, and the joke on this this annual question mark is that hopefully we can maybe do like an annual cancer symposium for you all, but this is kind of maybe the spitballing of the start of that. One of the resources that we want to make sure that clients are aware of, also for the staff at North Star Vets, is the fact that we have a veterinary social worker. So Chris Costello is a psychologist who works in veterinary social work. And basically that is, doctors, we can do all of the oncology and treatment speak, and really it doesn't matter what specialty, but specifically for oncology, when you have a cancer diagnosis, there's a lot of heavy weight that goes along with that diagnosis. So it's not just the financial aspect. Unfortunately, oncology treatments are expensive for the equipment and the resources that we're using, but also there's a lot of that grief counseling. And some of that is anticipatory grief because we have this diagnosis. We're understanding that our time is limited, but we can provide that quality of life. And at some point, we are going to have to grieve the loss of that patient for us and for the pet, for the family. So Chris, I've had many, personal conversations with her. She's a great resource. I'm a little biased because she was actually trained at the University of Tennessee as well. And Elizabeth Strand, who is a psychologist down there, was one of the people that actually started the veterinary social work program at Tennessee, and she is training other psychologists. So I think this is something that's becoming more important. It's becoming more prevalent in the veterinary medicine sector here. Just as another means of, we speak the science, they can do more of the emotional and the grief support. When we're talking about different radiation protocols, there's a lot of terminology out there. So just to go over some definitions, when you hear conventionally fractionated radiation therapy, those are kind of some of the starting standard protocols. The first ways that we gave radiation therapy were to give very small doses, but giving it a higher number of times. So 16 to 20 daily treatments would be a standard protocol if we're talking about definitive or curative intent radiation therapy. So sometimes that's between 16 to 20 daily treatments, Monday through Friday, or for our service, we're open Monday through Thursday. So sometimes that's over 4 to 5 weeks. Reasons why we would do something that's conventionally fractionated or definitive protocol is somewhere where we have a tumor that has a fairly good prognosis. The dog doesn't have, or the cat doesn't have, other life-limiting conditions. So no congestive heart failure, kidney disease, something where we can treat this tumor and we do have that time of prolonged survival with quality of life. So oftentimes we're talking about a survival time without other concurrent diseases of at least 12 months or longer. So an example of this would be 3 gray doses of radiation over 16 days. 3 gray being gray joules per kilogram. It's an amount of energy absorbed in a kilogram of tissue. And then we have stereotactic radiation. So now that we have the advent of advanced imaging, we're going to go through some of that. We have the ability to kind of have what we call sub-millimeter accuracy in our radiation beam placement. So because of the fact that we're no longer doing orthogonal films and kind of eyeballing the crosshair between CT setup on the day for the radiation planning and then crosshairs of the radiation beam on day of treatment. Now we have bone-on-bone overlay. Basically, we have a planning CT and the actual day of treatment image. We have a cone beam CT on the treatment platform. We can overlay those images so we know that our beam is off by less than a millimeter in the in and out, side to side, and up and down dimensions on our treatment table. So for this reason, we can actually give higher intensity doses of radiation, and we take that 16 to 20 daily treatment protocol and we condense it into 3 days. So the individual doses per treatment are much higher. We call it more dose intense. And when we're talking about intracranial lesions, which is exactly why, or exactly how stereotactic radiation was developed, it was for basically brain and spinal cord lesions. When we use that technology outside of the central nervous system, we call it stereotactic body radiation therapy, so SBRT. And an example of this would be 10 gray. So in comparison with this very small 3 gray, 10 gray doses, 3 consecutive days, we're doing that definitive intent protocol within 3 days instead of 3 to 4 weeks. Both of these treatments are intensity modulated delivered. So what that means is there's a multi-leaf collimator on the machine. So rather than just opening up an aperture and that hole is where we shine the radiation through and everything gets the same dose, there's individual lead leaves that help to shape the field. So that knocks off the corners of unnecessary radiation. Haven't seen a square or a rectangular tumor out there, so we can actually shape it to the contours of the tumor itself. But those leaves actually trickle the radiation dose over the tumor volume. So we can actually pinpoint and choose which parts of the tumor get a higher dose. So maybe that's the center of the tumor because we just want to blast it to the end of the day. And the other parts of the tumor that are close to maybe frontal part of the brain, if we're talking about a nasal tumor, or right next to an eyeball. We want to give a prescription dose, but we want a steep dose fall off at that edge so we're not getting unnecessary dose to the eye. That's what the multi-leaf collimator does, is it makes this fan-shaped beam and it's trickling the dose across the 3D tumor volume. And then of course with our machinery, we still retain the ability to do palliative therapeutic radiation, or PRT. This is a lowest number of overall cumulative dose. It's also a lesser dose intensity. So it's very similar to stereotactic radiation, but instead of giving 3 consecutive days of treatment, we do these doses once weekly for perhaps 4 weeks in total. There are some protocols out there that go out to 6 weeks. My impression is that we get our best effects palliatively if we're to do 4 weekly treatments. The cumulative dose is much less. So for instance, if we're doing 8 gray once a week for 4 total weeks, we're going to get 32 gray as a cumulative dose. We expect with a lower dose intensity, we're probably going to have a lesser tumor control time. So meaning time that we're going to marginally reduce this tumor and the time that we're going to keep it from growing progressively. So for this patient, Autumn Penorius, this was back in my residency, you can see that she has a fairly large nasal carcinoma that's exited the nasal cavity. It's actually causing exophthalmos or pushing out her eye. There's actually a lot of bony involvement with this tumor as well. So knowing that the survival time was not likely to be longer, because once we have tumor going through the cribriform plate, the bony plate between the nasal cavity and the brain, oftentimes if we did more aggressive therapy versus this palliative protocol, the survival time is going to be the same. So might as well space out the anesthesias, be a lesser cost to the clients, and still control pain for her. The dog that you saw on the table anesthetized, that dog, I could only take a picture while she was anesthetized because she was very fractious. Very painful from her nasal tumor to the point where we had to lead her down the hall with a leash and could not get close to her. This is about, I believe, the 3rd treatment. So after those 2 individual palliative doses, she could now let me hold her face. I actually picked her up from the waiting room and walked down the hall to the radiation vault for her third treatment. She was licking my face. So sometimes it's not that dogs are fractious, but they are fearful, or they have untractable pain that unfortunately we could just not get ahead of with oral medications. Radiation therapy provides some good analgesia, especially when we have tumors that go into bone, usually after the second week. So that's after the second dose with the palliative course, or about 7 days after stereotactic radiation is given for like primary bone tumors. And you can see on the CT scan, we had some of this disease up in the frontal sinus here. So this is the frontal part of the brain, left frontal sinus, and we also had some disease outside of the zygomatic arch in the mandible. So basically, I would say about probably 3/5 of the overall cross-section of this is actually her tumor disease. So not likely that we're going to have a longer survival time or a survival or quality of life benefit with more aggressive treatment. Another reason why we might do palliative radiation therapy is if we have a tumor that we cannot contain. So for oral malignant melanoma, we think these dogs will have a 90% chance of disease going elsewhere in the body. Maybe the more aggressive treatment in the local sense really doesn't give us a difference in overall tumor control and the remaining survival time. These dogs are going to pass on from their metastatic disease in the chest. So as long as we have local control, unfortunately, medical therapy or the canine melanoma vaccine, that can be used to prevent or push off the time to when we see the chest disease, but not really warranted to do a more intensive radiation protocol. So patients that have an expected survival time of lesser than like 6 to 12 months. Okay, we had this previous slide talking about CFRT, conventionally fractionated, the standard protocol, 3 gray, 16 to 20 times. The intensity modulated part of that's really just how the radiation is delivered. So IMRT, we used to call, once we had definitive and we just opened up radiation and, gave it, it was still conformal because we were still conforming the radiation dose around the 3D tumor, but we started calling it IMRT because now we're using the individual lead leaves. So now we can trickle the dose across the field. IMRT is the exact same delivery with a standard course as it is with stereotactic radiation. The only difference is the fractionation or the actual prescription, what doses we're giving per individual treatment. We already talked about that fractionation, stereotactic radiation, difference in intent. So we're still talking about this definitive intent, longer control time, hopefully with longer survival, but stereotactic radiation therapy is much more dose intense. We're giving those higher doses per treatment and over 3 consecutive days. And we already talked about the stereotactic body radiation therapy being for doses outside of the central nervous system. You also may see SABR or stereotactic ablative radiation because these doses are high. We're actually not only targeting cancer DNA, but we're also causing obliteration of like cell membranes, fracturing of proteins that are used for DNA synthesis, things like that. So stereotactic radiation therapy really has a 4-part definition. It needs at least these 4 parts to count. So the high dose intensity, we talked about the 9 to 12 gray individual doses per treatment, and usually that's given over consecutive days. The steep dose fall off, so with the varying linear accelerators, basically at the tumor periphery, we're going from 80% prescription dose down to 20% dose fall off within 2 millimeters. So that means at the edge of the radiation, we're not having this overbleed or this scattered radiation of the prescription into significant surrounding tissue. So it has to have a steep dose fall off. We also use advanced imaging. So during my residency, if we were doing conventionally fractionated or the standard protocols, we'd image on Monday. We'd mark the patient on the skin for where they set up as far as the laser beams, where the exact radiation beam center was. And then we treat them the rest of the week and we wouldn't image them until the next Monday. If you're giving individual doses that are between 9 and 12 gray, you absolutely have to image them every day to assure yourself that beam is within sub-millimeter accuracy as far as where it's placed. And then it's dose intensity, so it has to be consecutive day treatments. If we're doing these 9 to 12 gray fractions, but they're weekly, the dose intensity is lost. So now we're talking about a palliative course again. Stereotactic radiosurgery. So just like surgery being a single anesthetic event, radiosurgery is one anesthetic event. It's one high dose of radiation. So we might use this for nasal lymphoma in cats, something that's going to be very sensitive to the radiation. And maybe it's a patient that has other comorbidities where we can't do more than one single anesthesia. In pet care oncology, we also use this for microscopic disease. We also use it for mast cell tumors because they also react and they're exquisitely sensitive as a round cell tumor to individual single fractions of stereotactic. And then we talked about SBRT already. Okay, so the advent of the machine. So this is kind of a history of the progression of the variant linear accelerator. This is a machine that I worked at one of my previous jobs. It was from 1991. Lacked a multi-leaf collimator, so those individual lead leaves actually shaped the field. If you can imagine it, there was an acrylic sheet that we put inside this accessory mount. And in that acrylic sheet, there was holes where I got to put a 7 centimeter thick lead block and put a thumb screw on it and shape the radiation field. So we had multiples of those to form the radiation beam. If you can imagine, every time that linear accelerator turns, it's a new field shape because tumors aren't a sphere in 3D. So we had to run in, take that sheet out, move all the lead blocks, thumb screw them back in, put that back in, go out, image, and then treat. Luckily, we have the multi-leaf collimator. We don't have to do that anymore. The other thing that has been a real big help is some kind of onboard imaging. So onboard imaging is nothing more than some kind of imaging on your treatment system. So we do have the ability to treat with the, to image with the treatment head. This is MV imaging at the higher energy level of megavoltage. We're going to have a lot less of the photoelectric effect. Those high energy photons don't care what's in between them and the developing cassette. So a lot of this looks like very same, what do I want to say? Same contrast gray. Everything, you know, soft tissue, bone, everything looks about the same. Maybe we'd use this imager with something where it's like a nasal tumor, it's in a bony vault. We just need to see the outlines of the bones. If we have a KV imager on here, so this is very similar to the diagnostic x-ray tube that you have in your clinic. And then on the other side of the patient, so the patient would be on a treatment table here. Other side here is a detecting plate, so we can get those KV images. Lower energy, now we have more photoelectric effect. We actually have a difference in the density that forms the images, so we can see really bright white bone, really dark gray as far as soft tissues. If this machine is to turn around the patient while it's getting the image, now we have a cone beam CT. So that has helped us in doing our stereotactic radiation. So this technology started coming up when Varian started putting out these clinacs. So it was the first kind of linear accelerators from this company that had onboard imaging. Now we have a cone beam. It's actual 3D imaging that we can see this patient setup before we treat. Okay, so this was my residency. These are megavoltage images, and you can see that there's not a lot of difference between the bright white of the bone, radio opacity of the bone, and the darker gray of the soft tissue. So in this patient, we're treating a brainstem tumor. So when I had to set the patient up, this was an image that we shot with the machine. I had printed out what we call digitally reconstructed radiographs. So from the planning CT scan, we'd have this printout. I'd do this on the day of imaging when we were setting up the treatment. I would run to the other side of the University of Tennessee. They had this little like tuna can, soup can type of thing. You got inside, you turned it, all of a sudden you were in a dark room, developed the film, put a new film in the cartridge, because if we're off, we have to film the patient again. Run all the way back to radiation oncology and put these two up on the light box and say, how close is this to this? And you can see my little marks here. We needed to move the field 1.5 centimeters forward and 0.5 centimeter up. We do this image, 90-degree orthogonal. We'd also have a top-down image. And between those two images, we would triangulate where that radiation beam center was. Because of this, we were unable to do stereotactic radiation. We had to do the 3 gray 16 to 20 daily treatments because our radiation dose is going to be much less. That radiation field is also going to be a lot larger. The edges are going to be a little bit more fuzzy. Our certainty and where we're setting up that patient, much less concise. But now with, hopefully this translates well on the screen. But now with our cone beam CT, we actually have a 3D overlay, so you can kind of see the magnification screen. But the radiation therapist can take this little toggle bar right here and switch back and forth in between the CT scan and the actual day of treatment. So now by switching in between those, they can actually set up the center of that beam. We're doing bone on bone, soft tissue, tumor itself, we're overlaying those structures. So as long as that matches up exactly to the planning CT scan, we've got a sub-millimeter accuracy, way higher assurance, we can now do stereotactic radiation, we can treat the patient safely. Really cool thing is if you're doing a cone beam CT on like a intrathoracic tumor, you can actually watch the heart beat while the cone beam CT is revolving around the patient. Okay, this is our machine that we have at North Star. It's called the Varian Halcyon. It's one of the newest treatment platforms that comes from the Varian company. This, I believe, debuted in like 2015, I want to say. The one we have at North Star Vets is number 370 in the world, and that's both veterinary medicine and human medicine. Actually, the first patient that was treated on the Halcyon platform was a golden retriever out in California. So that's kind of cool. The 3 locations that we have in Peck here that have them is Sage in San Jose. We also have it in Houston and, of course, in Robbinsville as well. We still retain all the abilities of the different treatment modalities. So we can still do palliative treatments as well as conventionally fractionated, but now we have the ability to do stereotactic radiosurgery, stereotactic body radiation therapy, and stereotactic radiation therapy. Problem I have with this is that we don't have electrons. So because of the C-arm Linacs, we actually had a tungsten target. We put in the way of the treating electrons, we would get photons. If you move the target out of the way, now you can treat directly with the electrons. Electrons kind of come out in a teardrop shape, and they are superficially distributed. So scar lines after surgery, I love to use electrons for. Our solution to that is that we actually will put fiducial in our scar lines. So there was a study that was done with pet care oncology where we took a lot of dogs that were post-op and we put some liquid fiducial in there. It's called Pet X-Mark. It's basically an analog of like sucrose. It's an iodinated agent, and then I think like ethanol or some kind of alcohol. Cool thing about this stuff is you can inject it and it stays in the site without being metabolized for about 6 months. So if they decide to treat later and we don't have tumor regrowth, we can re-image this patient up to 6 months away and start radiation therapy at that time. The benefits that we've seen from this fiducial is actually in the intraoperative sense. So when a surgeon's in there taking out a tumor, or if you're in general practice, you're taking out a tumor, you can actually inject just under fascial planes and at the tumor periphery. That marks where the tumor was. Once we close those tissues, and because this substance is not being metabolized for about 6 months, we know exactly where those tumor margins were, and we can use it for stereotactic radiation targeting. If we were to just have a post-op scar line, there's no visible tumor, we're really unable to do a stereotactic treatment proficiently because we don't know where those high intensity doses, don't know exactly where the microscopic disease is left. You'll miss one cell, you have tumor repopulation, and after a stereotactic event, plus with the expense, that's a treatment failure by more than one measure. We also can't do extended distance therapy, half body radiation. Anybody heard about stage half body radiation for like lymphoma? My impression is that those dogs really didn't have an extended survival time. A lot of them unfortunately passed away from hyperthermic neutropenic deaths. So I don't think we're missing out on the fact that we can't put them on the floor and treat from an extended distance of the machine. This is kind of like a ring gantry, so it's kind of like a CT scanner. Basically, the table moves in, we treat the patient, we move them back out, but there's no table swings or anything like that. Cool thing is I can scan the dog sideways through a CT scanner. We can still treat them as long as they fit through this bore because it's a very similar platform to the CT scan. So we have 28 by 28 centimeter field size, and if tumors are located anywhere in that area, we can treat multiple sites. So if we have like a nasal tumor, we can also do retropharyngeal and mandibular lymph nodes. It's no additional price. It's really not an extension of anesthesia time for the patient. And it's a double stacked MLC. So rather than just one bank of MLCs, we actually have another bank of MLCs that's just a little offset. So it prevents some of that interleaf leakage of radiation. So if you have a regular linear accelerator, the multi-leaf collimator, in between the leaves, we're probably leaking through about 3% dose. This is less than 1.5% between those individual leaves as it's moving into the radiation field. So how do these machines stack up? We've probably heard a little bit about the CyberKnife. It's a different treatment platform. So the CyberKnife, rather than giving these multiple, pencil thin beams, these beamlets, there's an individual pencil thin beam that's given each time. And when I was speaking with my wife on this, it's not like a pencil that like skewers the tumor and we're doing like kerplunk if you've ever played that game. It's not like that. It's actually the pencil thin beam will go and it'll deposit radiation in a little sphere inside the tumor. So it's kind of like we're using marbles and we're filling up the tumor with these marbles or these dosing spheres. That's how the CyberKnife works. Unfortunately, because we're doing 100 to 120 plus beams with the CyberKnife, that means the anesthesias are going to be about an hour and a half per treatment. As far as the dose distribution or how we can conform that dose over the tumor, not a lot of difference in veterinary medicine. I think the benefit to go to the CyberKnife would be that Chihuahua that has that 1 centimeter brain tumor in the center of its skull. CyberKnife may have a little bit of a better dose distribution, but it definitely has its place. Dr. Siobhan Haney is the radiation oncologist there. We've swapped back and forth many cases, and sometimes it's the family that chooses, distance, availability, when they can get in the schedule, but just another treatment machine that's out there for you to know about. And of course, the Varian Halcyon uses a multi-leaf collimator to dose radiation, and these are the individual pencil-thin beams for a CyberKnife. Late side effects, so when we're talking about stereotactic radiation, we are worried about late side effects. So these are some of the effects that are actual prescription limiting. So death of tissue. We can see this for stereotactics, probably 1.5 to 2 years down the road. For CFRT, with a megavoltage, we saw about 5 to 8 years. So if we have a really young patient, maybe we need to do a conventionally fractionated protocol. 5-year-old dog is probably going to live at least 1.5 to 2 years and see late side effects. So fibrosis of tissue that will come up from stereotactics. So maybe we treat them with a standard protocol. They're younger, they're healthy, they could probably stand the 16 individual daily treatments and have a lesser chance of that late side effect of radionecrosis, which is death of bone tissue, or fibrosis, or scarring, such as soft tissues and central nervous system. Early effects, those are early inflammatory side effects. They're usually for superficial tissue or tissues that have a higher turnover rate. So the effects basically are based on cumulative dose. So the higher the cumulative dose of the protocol, we may have more inflammatory side effects. So that's something we have to concern ourselves with conventionally fractionated. For late side effects, this is the overall individual dose per treatment. And that risk increases with things like palliative radiation or stereotactic. So patient longevity is definitely a consideration. If a dog is going to live at least 1.5 to 2 years or later, we may see late side effects that come up. So for soft tissue sarcomas, we talked a little bit about liquid fiducial. This was a patient that we treated. Actually, Dr. Stobie, I believe, did a second surgery. The initial surgery had like clear margins, but I don't know if there was actually a measure of like how wide those margins were around the tumor that was removed. So second time around, because this was a recurrent tumor, excised the tumor and put in some fiducial for us to do a stereotactic protocol. When we're talking about soft tissue sarcomas, they grow by expansion. They also put in finger-like projections. So that's how cancer was named. Body of the crab, those finger-like projections are the legs. If you just scoop the tumor out, you're leaving the legs, those are going to regrow. With a grade 1 tumor, we think there's about a 10 to 14% chance of going elsewhere in the body, namely the lungs. So it's a good idea to get 3 of you thoracic radiographs on these guys for staging. Grade 2 is about a 20% chance, and depending on the publication you read, grade 3 has about a 40% chance. Means there's about a 60% chance it's not going to happen, but for higher grade tumors, there's always that concern for metastasis. Always worth a conversation, and at least educating clients on follow-up medical therapy with some sort of oral or anti-cancer like injectable therapy. And for older patients that may have that hemangiosarcoma that's hiding out in the spleen, before you're going to do curative intent radiation or a long chemotherapy course, it's good to stage them to find out that they don't have a bleeding mass in their abdomen. I have had a patient that was sent by a medical oncologist, no one in this room, not even in this location, but this dog was treated with 16 fractions on an ear tumor, and then 3 weeks later had a hemangiosarcoma that was bleeding and unfortunately was mainly euthanized in an ER setting. So this is a cross-section of patient, that same patient with the excised soft tissue sarcoma. And you can see these little areas of the fiducial that was injected at the time of surgery. And now we can create a radiation plan. You can see the overall dose here, so 33 gray. We did 11 gray per 3 treatments. This is the overall, what we call the planning target volume, or the PTV. So this is the tumor target plus a little bit of an expansion to account for microscopic disease. And this is the surface dose breakthrough. So on a stereotactic plan, I do need to treat that scar line to make sure that we're sterilizing cells that may be left on the scar. So that shows that we have a little bit of breakthrough. If we're going to have side effects, which we don't think, the inflammatory side effects are a very high chance with stereotactics, this would be the area that we can monitor. So I can print this picture out, give it to the client to say, hey, if we do have side effects, this is the area that's going to come up in, and it's going to be healed within about 10 to 14 days. Multiple surgeries for soft tissue sarcoma are not recommended. This is a dog where the gluteal region right here had a soft tissue sarcoma after the first surgery, just a scar line. Second surgery included this scar line. Third surgery included this scar line. And then the fourth surgery, I think, is where this disease and this disease came up. So now if we had a post-operative pathology report and it says that we have incomplete margins, if we can't take more tissue, so the scar line and an additional 3 centimeters in all directions for local control, that's the time that we need to maybe add in some therapeutic radiation to sterilize the field. The problem with this is this dog has been out a year and a half, has had 4 or 5 surgeries, and now we're doing radiation on this much larger field. For this, and because of the lesser control at this time, I believe his tumor may have upgraded, so gone from like a grade 1 to a grade 2. The survival time or the control time is not as good, so the client's elected for palliative. Mast cell tumors, real quick, we worry about the local mast cell tumor, low grade, or the grade 1 mast cell tumors, not a very high chance of going elsewhere in the body. If we get our surgical margins, that's usually all we have to do, and then we're just monitoring the site for potential recurrence. We also know that some of our shorter hair breeds, so like Shar-Peis, Pugs, Pit Bulls, stuff like that, they're going to form perhaps many novel individual mast cell tumors. Luckily, most of them are low grade, so you can just cut them out again. If they're not bothering the dog, get them on oral therapies. Maybe wait until you have a couple and then take them all off at the same time. Obviously, the ones that are in areas that are a little bit harder, you know, like pinna, muzzles, prepuce for male dogs and things, those are things you don't want to wait on. Probably need to get them diagnosed and taken care of sooner. But for mast cell tumors, basically growth by local expansion, they also can go elsewhere in the body, so local regional lymph nodes, and then onto the liver and the spleen. So always staging a dog with a, you know, if we're having like a high grade 2 to grade 3 or a high grade overall, definitely want to do more staging, make sure the disease isn't elsewhere in the body before we do local control. So surgery is usually 2 to 3 centimeter surgical margins, 1 fascial plane or 1 connective tissue plane deep. This is the highest chance of the tumor not coming back. If we can't achieve that, even with grade 1s, we can add on some therapeutic radiation afterwards. There's a question about, you know, if we combine these therapies, and especially for grade 2s, like high grade 2s and grade 3s, for higher grades, again, very high chance of going elsewhere in the body. My feeling is that when we're talking about like a high grade or grade 3 mast cell tumor, sometimes we're talking about a survival time overall of about 6 months, maybe longer. But that depends on if we can control the disease and if we don't have fulminant liver and spleen disease. So definitely get our medical oncologist involved with that case. And then this is overall just a demonstration on avoidance of skin surface. So this is a patient, basically we did a planning target volume of a patient that had, I believe this was like a caudal rib tumor, chondrosarcoma. But this just shows you the dose sparing on the surface here. So since it was a deeply located tumor, we're getting a little bit of cool dose here. So that's probably less than 50% of the radiation dose to the skin surface. This is not a patient that's going to have significant inflammatory side effects, but we are going to cause some alopecia for some time. It takes 6 months for this fur to grow back, and it often comes back in a different color. So we have this nice little leukotrichia or white color fur that returns. The good thing about that is now we have a monitoring window because that's where we gave the radiation. So now on subsequent rechecks, I can check this area for tumor regrowth. When we're talking about grade 2s, there was a study there that re-excision after primary excision where we didn't get margins was actually a survival benefit. So re-excision gave a median survival time of 8.6 years versus ones that could not be re-excised. We did a definitive course of radiation therapy and 6 years median survival time was given to that group versus if you did nothing, the median survival time for those patients was 2 years. And this is a patient with an electron setup for a scar line over the hip for a mast cell tumor.